Health Grand Rounds. We are delighted today to have Dr. Nadav Davidovitch from Ben-Gurion University in Israel joining us. Nadav is an old friend, and I'm happy to have him here this week, as well as Dr. Uri Shed from Ben-Gurion also. We are working on some autism projects together that will hopefully bear fruit in the coming years, and we'll have them back again to talk. Just a couple of quick announcements. We have some upcoming Grand Rounds. The March 7th Grand Round, same time, is Dr. Tarari Trent from the Tioga Foundation. She's also a fellow at the University of California at San Francisco, talking about HIV prevention in sub-Saharan Africa. And then April 4th, the Philadelphia Health Commissioner Don Schwartz will be joining us for a talk at the same time. Also want to announce Ethics Journal Club coming up on February 25th at noon. We'll be talking about vaccines this month. And that is it for my announcement. Dr. Davidovitch is from the Faculty of Health Sciences at Ben-Gurion University. He is both a physician and a historian. And we'll be talking about his work really in neither of those fields today, right? More of a public health talk. So I know Nadav, who did his training in Israel, but then came to the US, finished his PhD in history at Harvard, and then came down, did a postdoc at Columbia where I was, and has been really a great force in my career, helping me develop global ties, which has been much appreciated. So thank you, Nadav. Also, thank you to Julie Mostoff, who helped bring Nadav and Uri here through the Stein Fellowship mechanism, and then also to Mona and Al Sutnick, who, as part of the BGU network here in the US, have helped bring them here as well. So without further ado, Dr. Davidovitch.
So good afternoon. It's a great pleasure to be here. We have a very, very dense and fruitful week until now. What I'm going to present you today is our work in the Bedouin community centered on Bedouin women access to antenatal preventive services. And this work was done also together with Physicians for Human Rights. I'm on the board. And it's part of a broader project about health disparities in Israel. So some background you can see here. This is the map of Israel. And you can see this is Beersheba, where Ben-Gurion University is, Tel Aviv, Jerusalem, so you can get a bit of orientation. And you can see this triangle. Actually, this is where the Bedouin community is living after 1948. Of course, 1948 was an important point. After the war, the Bedouin community were moved into this area and actually were under military regime up until 1966. It's a long story, of course, and it has a lot to do also with public health. As you know, the politics of health is something very relevant here. So I started this slide with struggle over land and struggle over identity. I don't know how many of you are aware, but there are 46 unrecognized Arab Bedouin villages. Overall, we have in Israel about 200,000 Bedouins. About 80,000 of them are in the unrecognized villages. 60% under the age of 17, with a fertility rate. In 2004, it was 8.6. Now it's about 6.5. That's another interesting story that I'm not going to spend much more time today. The fertility rate is going down all over the country, also in the Bedouin community. This community actually is among the lowest socioeconomic groups and also have the lowest health indicators in Israel. In public health, usually we take infant mortality rates as one of the important indicators. So infant mortality rates are about 3 to 4 times more in the Bedouin community than in the Jewish population. And just to give you a bit of a image of the everyday life in an unrecognized village. So this is Wadi El Naam, and you can see across the road here, this is one of the major industrial sites in Israel called Ramat Chovav, and you can imagine, living in such a place, unrecognized, no roads, no health services for a lot of time, and of course, talking about social determinants of health, this is of course very important to understand the everyday life situation. Okay, so some background about mother and child health. As I said, infant mortality rates are about 3 times more than the Jewish population, where congenital malformation accounts about 40% of it. In the Jewish population, the main reason for infant mortality is mainly prematurity. I think also in the United States, this is the situation. In terms of maternal health, we know that morbidity among Bedouin women in reproductive age, this is data from the work of Twickel and Barak from 2003. We have UTIs, anemia, depression. We tend to forget many times the mental health, and also exposure to violence, 48%. If we take low access to health services for the Bedouin women, we can see that we are talking a very complex web of causation, low availability, extreme climatic conditions, lack of transportation, low or no access to resources such as education, funds, language, restrictive gender roles, I will return to it later, lack of childcare. So all of that is part of the general low access to health services, and I really want you to bear it in mind while I'm moving on with the presentation. So not everything is black. In 1994, we had in Israel the enactment of the National Health Insurance Law, and while in Israel before the enactment of the law, about 90% of the population were voluntarily insured. In the Jewish population, we were talking about 95%, in the Arab population about 80%, and in the Bedouin population even less, we're talking about 60 to 70%. So the Bedouins are Israeli citizens, and according to the law, they were entitled to health insurance, and this was of course a big advancement. But I want you to remember that health insurance is, also regarding the situation here in the States, when you have health insurance, this is not going to solve all of your problems, and also having health insurance, there's still lots of barriers, so it's important to remind. So when you have those unrecognized villages, you are actually in a catch-22 problem, because these villages are unrecognized. The recognized villages, I forgot to mention, were places where the Israeli government actually established since the 60s onward to move the Bedouins, and many of them refused to move, so they remain in the unrecognized villages. So those Bedouins are entitled to healthcare, but since the villages are not recognized, so you're not allowed to plan all welfare services such as education, meaning even just the structure of the house, connecting it into water, electricity. So together with Physicians for Human Rights, we went to the Supreme Court in the year 2000, and there was a decision that forced the government to establish 8 community clinics. In Israel, the name is Kupat Cholim, sick fund, and also 7 mother and child healthcare centers with 2 mobile units and also a mobile immunization unit. And this brings us to our study that we actually wanted to ask, is it an effective strategy to establish new mother and child healthcare extension in those unrecognized villages, and to see what are the remaining barriers? So in the study, actually, what we wanted to do to determine the effectiveness by comparing mother and child health services, accessibility, and utilization patterns, in two different settings. One, the catchment area of new mother and child healthcare station in an unrecognized village, and to compare it with unrecognized villages that they don't have a local mother and child health station. So they continue to use it, for example, in Beersheba or in the town or adjacent villages. So the study design methods was actually a mixed methodology. I'm a great fan of mixed methodologies. I think that both quantitative and qualitative methodologies really can, especially when you have such a complicated area of research, can really complement each other. So we took both quantitative, using survey among users, and also data extractions from the antenatal records, and also qualitative, doing in-depth interviews in the target population. And here you can see the population characteristics. So we took actually 3 different unrecognized villages, one that is urban and close to transportation, Abu Rabia, Batin, El Atrash. You can see the different locations, the number of questionnaires, and the inclusion criteria were women from unrecognized villages with at least one completed pregnancy. The qualitative methods was based on 16 in-depth interviews. We recruited the interviewees through NGO activists. Physician for Human Rights are working with local Bedouin organizations such as Yasmin El-Nakab and Ajik. Also, we approach mother and child healthcare center staff and locals. The duration of the interview was between 45 minutes to 2 hours. And the language was either Arabic or Hebrew, if the Hebrew was good enough. And we had also a moderator or translator from the local community. So now to the results, first the quantitative part. So in terms of the demographics, you can see here the mean age, parity, which is of course quite high, years of education that is unfortunately quite low, the husband years of education, illiteracy 35%, no written Hebrew skills or no verbal Hebrew skills. And even though I told you that we have a national health insurance law, still we have Bedouin, especially Bedouin women with no insurance, since we have sometimes Bedouins marrying Palestinian women. In our area, it's mainly from Hebron, and at least until now, according to the Israeli law, those marriages actually, they did not allow the spouse to have citizenship. And then we have the problem of the women and their children that actually they don't have health insurance. In Israel, even without health insurance, you are still entitled to visit mother and child healthcare centers. I know that's the situation in many countries in the world. You can see the self-rated maternal health, range 1 to 5. Comparing to the Israeli standard, this is quite low. Mean gestational age of delivery, birth weight, and previous loss of fetus or infant. That you can see, we mentioned the infant mortality rate, so it's quite high. Okay, so now to the results. We can see differences in terms of means of transport. If you remember, Abu Rabia was relatively close to Beersheba, so most of the women were using public transportation to get into the mother and child healthcare center that was located actually in Beersheba. And you can see here in Batin and El Atrash that most of them were going by foot. But it's more interesting to see the mean travel time, the difference, getting access to the mother and child station between the different different settlements, Abu Rabia, Batin, and El Atrash. 4 out of 5 respondents report that they have events of impeded access. Mostly it was because of lack of transport. Some of them lack of childcare or because of the weather. And we'll get back to it with the qualitative results. So if we can summarize until now the role of access, you can see that the location and the means of transport finally determines both the travel time, the predominance of the barrier, and also the dependence on chaperone, because actually according to Bedouin culture, especially if you're going to Beersheba, women cannot gather alone, and there must be maybe the brother, the husband, the uncle going with her. The mean waiting time in line, in terms of time burden, that of course affects satisfaction, we have, you can see 1 hour, 40 minutes, which is definitely a lot. And as you can imagine, the waiting hours extent correlates negatively with user satisfaction rates. This would be true for any population, of course. Here you can see the mean number of the antenatal care visits, which is definitely lower than the usual, let's say, Jewish Israeli, that it's more, the average is more 11, 12, something like that. The mean number of doctoral appointments to the physician, also quite low. The mother and child healthcare centers in Israel, like in other places of the world, mainly dominated by nurses. So the physicians is not there all the time, arrive there by appointment. And you can see that in our sample, about 14% had a total lack of antenatal care. And here you can see the timing of registration, and the mean gestational age was 17 weeks. 72% registered before 20th week of gestation, but definitely if we're thinking about congenital malformation, as I told you, this is the main reason for infant mortality rates. So a mean gestational age of registration of 17 weeks is really late. The reasons for non-compliance were lack of transport. About 50% of them were from El Atrash. And sometimes also, according to the perception by the women, tests that are being considered as unnecessary. Again, most of them also were from El Atrash. El Atrash, in terms of the education and illiteracy, I mean, this was the group with the lowest number of years of education and the highest number of rates of illiteracy. So if we want to summarize the quantitative results, we can see that the new mother and child healthcare station improved access in terms of travel time and independence from transportation and chaperoning, but on the other hand, we have findings on utilization and compliance that actually indicate a lot of remaining access issues. And this leads us to the qualitative part that was conducted after the quantitative part, where we really wanted to get into the reasons of why those barriers and understand better what's going on the ground. Okay, so we actually wanted to understand better the question of distance, time burden, transportation cost, hardship of a long and complicated journey, dependency from transportation, and dependency from a chaperone. And here I brought here some citation in order to explicate more those issues. So you can see, for example, one of the women from Umatnan, before they opened the Tipat Chalav is the name for TH is Tipat Chalav, the drop of milk, the mother and child station. I went to Dimona by foot on the dust truck to the highway, sometimes with a little child in the heat or rain. From there you can take a transit, it is far, it takes a long time, it is also expensive, the transit costs 10 shekels one way. So this was actually said that the opening of the mother and child station was actually a big improvement for this woman. And the second woman, before they opened the village Tipat Chalav, I depended more on my husband to drive me when he was at work or not free. I'd postponed the appointment. It happened a lot that I wanted to go on the Tipat Chalav, but I couldn't because I had problems with my transportation. So we have on one hand the improved physical access that diminishes the dependence from the chaperone, but on the other hand, as you see in a moment, still there are language problems and limited capacities for autonomy that still keep the chaperone's important role. You can see here the woman who cannot go alone when their husband works, so they miss the appointment if there is no transport. Or the second woman, when they send her for test to Beersheba, her husband accompanies her. If he's not free, she is not willing to go. She's only willing to go with him. He doesn't allow me to go alone because I don't manage due to the language and because these are complicated places, especially Beersheba. I must say that many times the men are Hebrew speaking because because of the work they have much more interaction, while women remain in the unrecognized village and has less interaction with Jewish Israelis. Okay, so you can see the language and barrier ramifications here. So misunderstanding, left information transfer that of course influence delay in healthcare seeking, mistakes, less educational and counseling. Of course, there is an interference with the suppliers and patient relationship, frustration, embarrassment if there is a translator. So it's not always a good solution, of course. And of course, finally, it leads to lower quality, disencouragement, and less compliance. You can see here some examples. Sometimes I have a problem and do not manage to explain myself. The nurses and the doctors gives counseling and explain the test, but in Hebrew. I felt very bad because I didn't know to explain that my baby's problem to the doctor. I had to wait until my husband came and explained in my place. I understood that there is a problem with the girl, and it hurt me a lot that for such an issue too, I need to wait for my husband to do it. For a simple thing like explaining my daughter pains. Another interesting factor was what is called in Hebrew lachatz. Lachatz is pressure. And it's interesting that those women that were doing even the interviews in Arabic, they were mentioning the word lachatz in Hebrew. So the interviewees consistently characterize situation in the mother and child station with the term lachatz. And during the interviews, it related to different reasons: the short opening hours, understaffing, limited special capacity. So, of course, the sequel is long waiting hours, overcrowded, delays in the healthcare, and a very tense atmosphere you saw before the waiting line. So, again, some examples. The village, Tipat Chalav, is open only 2 days a week. That causes a lot of lachatz, and sometimes the staff receives only a part of the women who seek treatment. Or another woman, she went to Tipat Chalav in Dimona, meaning not in the unrecognized mother and child healthcare center in the unrecognized village, but went far away to Dimona because of this pressure, because of the lachatz, and also because she understood that the lachatz in Tipat Chalav causes a lower service quality. She heard from another woman that due to the lachatz, immunizations were given with a delay. Another issue is the question of availability of tests and drugs. Rather sporadic knowledge on procedure and meaning of the test and the requirement to seek services from secondary health facility finally leads to access problems that remains as before the new mother and child health stations were established. And of course, it applies also to the low or even non-availability of drug in the local clinic. So of course, when you have a new mother and child healthcare center, but finally you get a prescription and you need to go anyway to the city, so it makes less sense that you want to use those services or you go anyway to the far away since you want to go a much more comprehensive and services. So again, some illustrations. They do not do ultrasound or tests here. They do not do anything here. All they do here is wait and iron. All the rest they do in Beersheba. There is nothing here. That's very hard. Some might have done one television. This is the kind of way that many women are describing the ultrasound test. And so they think that there is no need for another one. Maybe the nurse explained, but the woman did not understand exactly what the purpose of the television is. Another important component that came in the interviews was the question of affordability. Service costs that were not described as deterrent due to high priority for health, and transport actually were considered as much bigger concern. So this was an interesting fact that came out during the interviews. And finally, those women, since are financially dependent on their husband, this is of course a big problem. You can see here about 170 shekels every month. It can be up to 300 shekels, but never more than that and never less for mother and child each. So tests for Tay-Sachs are also very expensive. That's another reason why some women did not do the test. At that time, there was a copayment. Now, also following our study, this was the copayment was cancelled. Another question, of course, is the question of gender and cultural sensitivity in staffing. And here it's interesting to see that there were divergent preferences around the question of gender or cultural identity and language skill. Although usually women prefer that to be a female, not from the same community because the question of gossip, and also Arab speaking. So interestingly, usually there was a large rejection of Bedouin male physicians. So you can see, for example, this woman saying a Jewish doctor would be preferable because they want gossip. It's an interesting description of a Jewish doctor. A female doctor would be even better. Then it was not important if she was Bedouin or Jewish. I'm shy with a Bedouin doctor, maybe simply because he's a man. There is a case, a woman who stopped treatment. She started with Dr. T, female, but now that there is a man, she stopped. She's not ready to go. Another important question is the question of privacy. And many times the involvement of a translator, if let's say it's a Jewish physician or nurse, violates the interview sense of privacy and self-esteem. And here you can see again some citations. Sometimes the nurse runs out in the middle of the examination to find a translator, somebody in the clinic or walking outside. Of course, this is a problem with privacy. It's not convenient to talk about something personal, about a problem where there is other person and the second woman, and sometimes the husband stands next to his wife and is shy to explain to her, or she's embarrassed about certain thing which he translates to her. So many times the husband are being used as translators, and this is, of course, can be also a part of the embarrassment and another barrier. In terms of satisfaction, so we understood that there was an improved satisfaction related to access, but in terms of the quality was perceived as low, again, because of the pressure, language problem, unavailability of drugs. So if we want to make some conclusion for our study, so we can see here that we have on the one hand a mother and child healthcare setting behavior that is a result of a balancing process in a situation of perceived dichotomy. So we have on the one hand the old mother and child station that were perceived as less accessible versus the new mother and child health station. But on the other hand, we have the other balance about quality, that the old mother and child station were perceived as much better quality than the newer mother and child stations. When we are discussing the balancing between barriers and the user options, you can see again the question of resources and capacities, what are the priorities and motivation for the health-seeking behavior versus the deterrents and barriers. And finally, this constitutes the whole health-seeking behavior of those women and actually explain why some of them are still continue to go to the mother and child healthcare station in Beersheba, for example, while for many years they were fighting to establish those mother and child healthcare station in the unrecognized village. So this study was conducted in 2006, 2007. We issued a report that was presented to the Ministry of Health. Part of the recommendation were regarding to the question of staffing. We definitely thought that it would be much better to have Arab-speaking both nurses and physicians, and to have females also. We introduce into Ben-Gurion University a course for Bedouin women health promoters that can serve as mediators, and now they are being hired by the Ministry of Health in those mother and child healthcare stations. In terms of transportation to the village, to the mother and child healthcare stations, they are also together with another NGO. There are now some specific transportation that being conducted on a daily basis. Also hooked up with the transportation to the schools. So that's another very useful combination to have the mother, children, being transported to the place. And also we made recommendations that was also adapted to increase efforts to make procedures to be much more transparent and understandable in terms of the medical examination, referral fees. All the materials were translated into Arabic. I'm not trying to say that before that there were no Arabic materials, but now there are much more materials. Some of them also with illustrations, also being used by those health promoters. And of course, this is for the benefit both of women and the children. The mother and child healthcare stations became also kind of a community center where we are conducting also some health promotion activities for the families. For example, about smoking cessation. This is a huge problem in the Bedouin community. Smoking rates in the Bedouin communities among men is more than 50%. The average in Israel now is about 28 to 30%. And women, of course, in the Arab not of course, but women in the Arab community are smoking much less. It's something around the Bedouin community 5%, and higher in those who are educated in the university, and maybe they're being more exposed to that. So the mother and child healthcare station are also being used for health promotion in general. So again, it's a half empty, half full glass. And finally, we do think that there is a need to have more mother and child healthcare station. But I think one of the take-home messages would be that it's not a black and white, either there is a mother and child healthcare station or there is not. But there's also the question of, okay, if there is a mother and child healthcare station, for what is the quality of care? For example, the hours of opening, for example, the availability of drugs and ultrasound services in the place, the availability of pediatricians and obstetricians, and just check the list and say, okay, we have a mother and child healthcare station. This is of course not enough, and with opening hours for just 2 days a week, this is a very problematic. So altogether, we do think that this was a very successful move, but definitely we need to care about the quality. In terms of the health staff, several years ago, we established at Ben-Gurion University a special nursing program just for Bedouin women. They are now going to graduate the first cohort. We have already several lessons that we learned. The first cohort, they had one preparatory year, and they were studying in one class, separated from the other nurses, and Now we think that probably it's much better to include them all together. And those nurses now are going back to work in the community, and this was a great success. Some of them are working in community clinics that I mentioned that were established in the unrecognized villages, and some of them are working in the mother and child healthcare station. Just to bring you a bit more of a context of what we are doing. So this work, as I said, was conducted together with Physicians for Human Rights, but in general, this was part also of what we have in Ben-Gurion University Faculty of Health Sciences. It's a forum for health policy that we bring together different stakeholders, both from the academia, from NGOs, from the sick funds operating in the Negev, and also from the Ministry of Health. The idea is to conduct similar studies together with the community in order to improve the services. 2 years ago, we established what is called the Mitzpe Ramon Health Disparities or Health Equity annual conference. It was a huge success. The idea is to have working groups having discussions, small group discussions, and preparing white papers for the conference, working several months ahead. Then in small groups presenting it to each other, and the second day presenting it to the public, including the media and to parliament members, and then presenting it as an official report in the parliament and also to the Ministry of Health. And this work was part of our first conference. We had there 3 different working groups, one about regulation, one about discrepancies in manpower, especially how to bring physicians and nurses to the Negev. And the third group, that this was part of the work, was about public health intervention, especially targeting the Bedouin population. Next year, we're going to discuss rehabilitation issues, and this is where the autism part we think can really fit in nicely. And I think it's a great model in terms of having the university as an objective. I'm not thinking that the university is objective, but I'm thinking that at least it can be perceived as an objective facilitator that can bring in, the different stakeholders with all the internal institutional politics, and put them around the table and have the discussion in a nice, relaxed atmosphere where people can trust each other. It's definitely not such an easy task, and believe me, I'm both a physician for human rights. It's quite a critical organization, as you can imagine, about many of Israeli policies. But on the other hand, when we can, we try to cooperate also with the Ministry of Health. Another example that I'm not going to present today, this will be next time, is the question of asylum seekers' health. That's another very important debate going on now in Israel and also here in the States. And there also we're trying to do similar things using mixed methodologies, both quantitative and qualitative analysis, and then to present it in small groups and finally to make recommendations. So it's exactly, I think, the public health idea of moving from science to the community in order to improve public health. Thank you very much.
Comment and then a question. What you're describing here is not all that different from some of the situations we have here in America. You only have to think of the colonias along the Texas-Mexican border that are not all that different from your unrecognized villages in terms of their access to care and community, basic community things like water supply. I was wondering if you could fill in just a little bit more what the Bedouin community members do. My understanding is that there are some Bedouins that are still fairly nomadic. They travel from Jordan through Israel into Egypt. There's issues there. And the very specific question I have, you commented, and it's obviously a multifactorial issue, that there was a higher rate of congenital abnormalities. I was wondering, given the map you showed us in the beginning, if anybody's ever looked if that has anything to do with Dimona.
Wow. Okay. So for the first question, there are definitely no nomadic anymore. Maybe some of them are semi-nomadic. Many of them, it's definitely a society in transition, classic society in transition. So now they're facing problems like diabetes, especially women, many other chronic diseases. So probably similar things that happen here with the Native Americans. And so you have many of them moving to relatively large cities that were constructed by Israelis. The problem was that the whole planning process was quite horrible. So mainly, houses, almost nothing else. So it's kind of asphalt. And so then you have problems of crime, unemployment, etc. And then you have those who refuse to move. And now there are still negotiation going on between the Israeli government and the Bedouins. Several years ago, a former Supreme Court judge, his name is Goldberg, there was a Goldberg committee that issued some recommendations. Then Netanyahu government came into power. They thought that maybe there are too generous recommendations. So there was another committee. Right now, most of those Bedouins actually are boycotting this whole process. Actually, I'll be in a meeting next week in Tel Sheva. I'm I teach a course on conflict resolution and mediation in the healthcare system. So I'm kind of a guy that, although I'm a physician for human rights, that they have the reflex to go to the Supreme Court many times. And sometimes, of course, they're right to do so. We're trying now to make some negotiations. We need to remember that many of them actually, we have now lots of professors, Bedouin professors at Ben-Gurion University. The head of the School of Pharmacy is Bedouin. We have physicians, nurses, so definitely there's a big advancement. In terms of gender issues, it's an interesting process because many of the women now are going to the university more than men. And sometimes they're telling us, if I won't go to the university, I'll be married when I'm 18. So they want to postpone it, in a personal kind of conversation. But sometimes, after they get the BA, master, PhD, it's not so easy to find a husband, that that his wife would be, a PhD a student. And of course, it's not a monolithic society. So, and you have different tribes, and you have lots of issues as well. By the way, just where to locate the mother and child healthcare station was also a very political question, because let's say that you have an unrecognized village with 3 different tribes, and you're situating, in the midst of one of the tribes. So you can imagine how it can create a huge debate within the community. So it's definitely a society in transition. By the way, many of them are also serving in most of I don't know if most of them, but many of them are serving in the army. Sometimes they're also in unrecognized villages. This is really crazy situation. And they're Israeli citizens. And at least the National Health Insurance Law gave them access like any other citizens, but you still can see, I think this is a difference between what's happening here in the United States, where you have this huge problem of people that are not insured. Now with the Obama reform, maybe it will change.
Colombians actually are American citizens.
Okay, sorry. Yeah, but you're absolutely right that a lot of similarities. But here I really think that it's really important to use both the quantitative and qualitative methodologies to understand exactly, to have the local knowledge, what are exactly the barriers and how to try to overcome those barriers. Sorry? Dimona. No, the main thing with the congenital malformation is family marriage, actually. And of course, here it's very delicate, and I think at Ben-Gurion University, including, I know that our current president, Professor Rivka Karmi, used to be the dean. She's also a pediatrician and geneticist. And she told me in a personal conversation once that she now understands, the studies that she was doing in the 80s and onward, that now she also understands, how you must bring in, people from the social sciences and humanities in order to have a much more community-based participatory research, and how to work together about priorities and present the results. So I don't think that Dimona would be a major issue, but Ramat Chovav industrial site is definitely an issue regarding a question of air pollution, and yeah. So there are definitely higher rates of respiratory diseases. Ben-Gurion University, there was a huge study conducted about it. By the way, there is a big improvement with the air pollution. But still, the Wadi el-Naam population, they live just across the road, and people sometimes forget that it's not just the air pollution, but just the explosion of, dangerous materials that can blow up the whole area. It's not funny, by the way. And this is why it's so unfortunate that they are now boycotting this process, because originally it almost agreed, the Wadi el-Naam agreed to move into Segev Shalom. It's a bit to the north, but finally everything exploded. So there's still no solution.
Thank you for a wonderful presentation.
Thank you.
I was wondering a little bit about the birth experience that are attending health centers, where they're delivering, if it's at the hospital, at home, who is the birth attendant, a bit more about that.
Right. So it's interesting because most of them, they give birth in the hospital. And one very practical question, and this was the reason why it was enacted originally, that in order to get the birth allowance, let's say in a simplistic way, that you should, it's much easier when you're doing it in the hospital. And this was done during the 50s, when there were also lots of transit camps, and the problem of deliveries outside the hospital were also a problem within the Jewish immigrant community. So most of them are giving birth in Soroka Medical Center. This is the busiest, give birth, place in Israel. And usually, by the way, it's interesting that comparing to Jews, Bedouins are pretty much pro-vaccination, pro-medicalization of, they believe in all the science, and many of, not all of them, but most of them really think that, it's an excellent thing, and it's part of, again, I talk about society in transition. So most of them give birth in the hospital, for sure.
Maybe I missed it, but did you measure differences in outcomes of pregnancies between those with clinics on site and those women who had to travel?
The main, after adjusting in, doing a multivariate regression analysis, so the main factor was when was the first visit to the mother and child healthcare centers. This was, after adjusting to that, everything else was not statistically significant. This was the main factor. So the main question is how to bring those women to get the follow-up. Otherwise, there were no statistical differences. But I think that the whole question of satisfaction and self-perception is also very important. And definitely those women that were waiting, long waiting hours and this whole pressure thing that all of them were mentioning, this is something that we should also take into account. Now, yes, at least at Ben-Gurion University, I'm partly responsible for the introduction of those things. I don't want to sound naive and tell you that all medical students are extremely interested. I must say that at Ben-Gurion University, probably it is more emphasized than in other universities. We're actually doing now a study about comparing graduates of Ben-Gurion versus other, and the bottom line that Ben-Gurion University graduates are more community oriented. So yes, we introduce it. At Ben-Gurion it was introduced since it started, but probably by the late 90s, early 2000, it was a bit diluted, but right now, yes, it's being introduced also throughout the years. By the way, in Israel, we have a system where you go immediately to medical school. So it's 6 years and 1 year of internship. And there is exposure to the hospital and clinics already on the first year. Of course, not doing clinical work, and then we are discussing also ethical issues and other stuff and cultural competent issues. We have modules on health disparities, so then we're also introducing that. And we're doing also simulations. There are always things to do, but it's definitely on our radar.
It sounds like create better transportation needed. Currently, a little bit hard to get to clinics, but that's an ideal.
Okay, so many times the trick would be maybe to do a pilot, and that's what we did sometime with money arriving from NGOs, donations, etc., and then to present the outcome to the Ministry of Health. And right now we are very lucky that the current Director General of the Ministry of Health, a Ben-Gurion University graduate, is very, very open to issues of health promotion and health disparities. They develop kind of different pillars, in their program. So they even opened a new department for dealing with health disparities several years ago. Right now it's only 3 people, but we hope it will be enlarged. And sometime again, it's using not just health-related money, but for example, doing it together with education. So, for example, as I mentioned, to take women and children on same transportation to schools and also to the mother and child healthcare center. So you need to be quite both flexible and also creative. and do the follow-up and evaluation and continue to press and make your and lobby and sometimes finally you go to the Supreme Court or in order to from a more human rights kind of perspective. So you need to use different approaches, public health approach, human rights approach, cost effectiveness approach, and to present in different languages to different stakeholders. That's also something that it's important, I think, to teach in a public health school. For different audience, there are different way to persuade them. So there is no short answer probably to your question, but finally we succeeded.
This was wonderful. Thank you so much. Have you or have there been comparative studies of some of the same access questions and some of the same issues with the immigrant communities and refugee communities in the Negev or in other communities?
Yes, I mean, I'm talking not only just about Mother and Child Healthcare Center, but in general about those different barriers. We did a study mainly dealing with the former USSR population. There are studies also with the Ethiopian populations. And of course, some of the themes also, this idea that access is a very complicated concept, and there are different levels, and you need to, you have the structural barriers, you have the economic barriers, the cultural barriers, and it's interesting to see that for physicians, and maybe this is related to the cultural competence, for physicians usually it's much easier to accept the cultural barriers. Structural barriers, it's more radical in a way because it's shaking the political status quo, because it's already about question, how the allocation of funds and power relationship. But yes, there are other studies that were conducted. Usually it's not exactly comparative, so we were focusing on a specific population. But you're right that maybe it would be interesting to do a more thorough kind of comparative analysis, definitely. Okay, here I must say that I don't have good messages. Mental health in general in Israel is underfunded. Just recently we had a reform which should be moved from the responsibility of the Ministry of Health to the sick funds, non-profit sick funds that are operated according to the National Health Insurance Law, and they're giving the clinical care. But up until now, mental health was in the Ministry of Health hands. So in general, it's underfunded, and especially regarding the Arab population. So we have a psychiatric hospital in Beersheba, but definitely we need to think more how to, to bring staff and open maybe a mental health center. And of course, the language barrier here is a major barrier. I think there may be 2 or 3 Arab psychiatrists in Israel. There are many physicians, but not many of them are going to psychiatry, and also in psychologists, etc. So it's really hard, to give mental health consultation, and there are lots of mental health everywhere in any population. For example, depression is really something that is being very neglected. So it's a kind of a tip of the iceberg, I think, in terms of what exactly we know. But mental health is less of a field that I'm specifically doing research, as just interested from the health disparity point of view.
Thank you. Oh, one more question?
The hearts, the uncomfortableness, the tension seems that one of the parts of this is very across all backgrounds. You can apply this to many, many things. Is there any data that you guys have that whether this level of hearts stands out or is the typical amount for comparatively old versus new?
Sorry, it was a bit hard for me to.
In the qualitative part, many people talked about the tension.
Yeah, the pressure.
Do we have any data whether that is similar or increased compared to the old centers?
It's definitely increased, and partly because, as I said, it's not just about establishing a new mother and child healthcare center, but it's also about the quality and about the opening hours. Are some tests and drugs available? Yes or no? Facility itself. So definitely, the older mother and child healthcare center. But this was definitely in the last 4 years or so. It was definitely improved. We took our students just 2 weeks ago for a tour in some of those schools, and I was myself astonished to see the improvement. But again, I'm not trying to portray a wonderful picture. There's still a lot of see, this is one of those women walking. So you can imagine walking to those places that can be miles away. But still, there are improvements. There's still a long way to go.
Okay. Why don't we hold the question? You can ask it afterwards because it's getting late. But thank you very much, Dr. Davidovitch.